recording on as well, because this might actually, this can, as long as you're happy for it too, mate, what this will probably double up quite nicely as, since I'm obviously doing it with one of my clients, I'll probably just upload this into the group so that everyone can see this, because this might actually be quite beneficial. So if I scroll down to the PMS section, because obviously what you've specifically asked is, you know, how do we then kind of actually work through this when we've got these answers? So let's start here and then kind of work out how that flow chart kind of is, for example. So these are, for anyone that's going to tune into this, if I do just upload this as a lesson into the group. So we are just going to work through kind of as a case study. This is a new client. I signed her up maybe Saturday or Sunday, and obviously it's Monday today, and I haven't even looked at her forms yet. So this is the first time of me seeing them. I haven't looked at these yet. However, from the consultation, which we did in person, she's an in-person client. From the consultation, she mentioned PMS, and we chatted about that a little bit. So I know that opening these forms up is going to obviously work nicely for what we're trying to achieve here, which is to work you through and kind of give you the, I guess, the behind the scenes or a case study. So I've scrolled down to the PMS section, because we're going to start here and kind of work out, right? So all that I know for now, the only thing I know is that she does have PMS, because she's told me that in person. I haven't looked at the forms. So this is my PMS section, and you can see what I've written here, and I'd recommend everyone does this. So I'd recommend you do this too, buddy, is because I had a call with one of the girls in here the other day, and I would recommend having a separate PMS section. The reason being is you can have your low progesterone section, and you can have your high estrogen section, and they might be /are the root causes of PMS. But obviously PMS is kind of referring to a specific time frame. It's referring to that luteal phase, right? So when we're talking about signs and symptoms of low progesterone and or estrogen dominance, we're kind of, that could be referring to any point in the cycle, really. It's not really time frame specific, and it's not even menstrual cycle specific. So your client might not have a menstrual cycle, but they might still have some signs and symptoms of like estrogen dominance, for example. It's going to obviously be a little bit different if they don't have a menstrual cycle, because they won't actually be producing estrogen, whether that's because they've lost their cycle or because they're on birth control, whatever it might be. Obviously that becomes a separate problem. But the point is, estrogen dominance and low progesterone are not necessarily time frame specific around the menstrual cycle problems, whereas PMS is, it's pre-menstruation syndrome. So it's specifically referring to pre-period, okay? So at most, that is going to be after ovulation. So if it's a 28-day cycle, then obviously ovulation's probably day 14. If it's a 30-day cycle, ovulation's probably day 15. But it's pretty rare that females have PMS starting this far out. Sometimes they might experience a little bit of a few symptoms and issues just after ovulation. Then they typically go away, and then typically PMS lasts for 3 to 5 days. So in that late luteal phase, right? So because we're now referring to a specific time frame, a lot of these questions, a lot of these here, I've already asked them, but here I'm asking them specifically referring to this late luteal phase. And the reason that that's important is one of two reasons. The severity might increase, or they might only experience these symptoms for 3 or 5 days. So if I didn't have a PMS specific section, and then let's go up to my high estrogen section, estrogen dominance, they might go, well, you know, do I have this or do I not? Like, I do a couple of days of the month, but I don't have it all the time. So should I put yes, should I put no? And you might not kind of get accurate answers. Okay. So if you're specifically having this here going, this is just referring to that late luteal phase, then people kind of know how to answer it. Does that make sense? So I've got the high and low estrogen, the high and low progesterone, but then also PMS has its own section just referring to that late luteal phase. So now whether the severity of these symptoms has increased, or if they are just present but only present here, they can now answer that this section kind of separately. Okay, so that's kind of part one, is to have this PMS specific section. I have just, you know, said the difference between PMS and PMDD. make sure you work with your doctor, you know, and these symptoms would typically disappear once your period has started. Sometimes a client may still experience these symptoms for 1 or 2 days, the first 1 or 2 days of their period at most, but typically they go kind of as soon as menses has started. Okay, so that's kind of a little bit of a recap as well, but that's just, I guess, kind of part one. So there's always 2 parts to how I do this now. Part one is we do need to refer to the sections. So does she have PMS? We can quite clearly see the answer is yes, right? Because there's lots of ticks. So based on that definition of PMS, of it needs to have at least 4 symptoms. Okay, has she ticked at least 4? Yeah, she's ticked like what, 10 or whatever, right? So obviously, yes, she has PMS, okay? So we need to address kind of the individual symptoms, but also just the section as a whole. So does she have PMS? Yes. And then with the individual symptoms, the reason why we don't just want to brush over the individual symptoms and go, yeah, she has PMS. Okay, cool. So let's just treat PMS. Obviously, that's not really a great approach. That's a bit broad. Okay, if we do that, we're not treating the individual symptoms, because remember, that could be different person to person. One person's PMS isn't always going to be the same as another person's PMS. So we need to look at the individual symptoms in terms of A, giving us more insight into what the root cause might be. B, trying to address and manage and help the specific symptoms. So how we do that for a headache is obviously not going to be the same as joint pain, right? What you do for joint pain is not going to be the same as what you do for a headache. So we need to look at the individual symptoms as well, in terms of just helping to manage and deal with and cope, and maybe even quote unquote fix the individual symptoms. But also lastly, we need to look at what those individual symptoms are, because we need to decide, does she have, and the answer here is quite clearly yes, but does she have PMS? Or let's just say she'd only ticked these 2. For example, let's just say she ticked muscle pain, okay, and bloating and cramps, for argument's sake. Now, technically, because that would only be 2 symptoms, technically it wouldn't be PMS, because the definition is 4. But forgetting that for a second, let's just say she ticked those 2. So now the next thing we need to ask ourselves is, okay, even though she's ticked them under this PMS section, could the root cause of these symptoms be the section that we are on, or could they be something else completely? Because she's ticked so many, okay, yes, she definitely has PMS, but let's do a different one. Let's do a better example. Let's do the low and high estrogen, because this is always a really good one. So she's ticked 1, 2, 3, 4, 5, 6. She's ticked 7 under low estrogen, 1, 2, 3, 4, 5 under estrogen dominance. So she's actually ticked more in low estrogen, but the severity of them, she's put more in the 3s and 2s in high estrogen. So now, in terms of deciding, is this estrogen dominance or is this low estrogen? Firstly, it can technically be both, because obviously estrogen fluctuates throughout the menstrual cycle. So, maybe she has some of these low estrogen symptoms when she's in a low estrogen state, the late luteal phase, the early follicular. Maybe she has these symptoms in the late follicular and the early luteal when estrogen's higher. So if you ever see this, we now have to do 3 things. We have to go, okay, what one is it? So this isn't the best example, because normally what we'll see is the client might, have 1, 2, or 3 ticked in low estrogen is typically what I see. Okay, and 6, 7, 8, or 9 in high estrogen. So then I can kind of look at that, and just as a blanket initial thought process, I can probably say, based on the amount of symptoms ticked, that low estrogen isn't the problem, because there's significantly more ticked in estrogen dominance, and maybe the severity is more as well. But then also we look at the specific symptoms. Okay, now can depression, can memory loss, and low motivation, they can kind of all be caused by high and low estrogen. So say they were the only ones she ticked in low estrogen, I can probably say that low estrogen isn't a problem for her because the one she has ticked under here, she's also ticked in high estrogen, and there is also more other symptoms ticked in that section, or it's more severe. So then I can say, hey, we don't even need to worry about this one. But for her, she has ticked some symptoms that aren't going to be caused by high estrogen, part one, and she's ticked quite a few. It's fairly even. So for her, it's either not low estrogen, it is just high estrogen, and these symptoms are all being caused for something else, or she is just experiencing both kind of throughout the menstrual cycle. So now my next port of call will be to ask her a couple of questions around the timing of these symptoms to try and paint a picture, you know, of, are you experiencing all of these kind of the whole month around, or are you experiencing these ones here and these ones there? So I'm just starting to dig a little bit deeper, right? So I know that isn't crazy straightforward and systemized, but the reality is, you know, you will get an individual reply from the individual. It's always going to be a bit different. Sometimes it'll be easy. They'll tick 7 boxes in here, 0 in here. Easy.
I see.
Sometimes like this, it's like, oh, okay, I need to dig a bit deeper because it's actually pretty similar, right? So now I need to ask her some questions to try and understand, you know, is she experiencing both throughout the cycle? Could these symptoms be caused, you know, elsewhere? Because she's nowhere near 40, so she shouldn't have low estrogen. If it is low estrogen, then it will just be those couple of small snapshots in time in the cycle where it is low, okay? Also, what we then obviously always need to remember is, does the client have a menstrual cycle? Because if they don't have a menstrual cycle because they're on birth control, then if they are ticking high estrogen, it will not be because of estrogen production. They might still not be eliminating the synthetic estrogen. So all the same problems might be relevant, not passing stools, the gut or the liver. Okay, all of that could still be relevant. But if they are on birth control, their estrogen dominance is definitely not caused by them producing too much of their own estrogen. It can't be because they're not producing their own, at least not from the ovaries, right? Because that's how birth control works. They'll produce a little bit in the adrenals. So we kind of always have to go through this step-by-step kind of process, right? So for this client, part one, does she have a menstrual cycle? Yes. Not on birth control, she hasn't lost it, okay? Could early onset menopause be a problem at her age? There's like a 0.00001% chance at 32 she's going into early onset menopause, so probably not. Which means I'm leaning towards the problem being estrogen dominance, not low estrogen. However, there is a couple of points in the menstrual cycle where her estrogen might be low, that late luteal phase and that early follicular phase, when we're preparing to shed the endometrial lining and when we are shedding it. So maybe some of these symptoms, okay, are just caused by the low at that specific time frame in the cycle. But if we dig a bit deeper, depression, there's loads of reasons someone could be depressed. That might have nothing to do with estrogen, okay? So I would dig deeper on that. Joint pain, that could have absolutely nothing to do with estrogen. And low motivation to train, that could be environmental, that could be neurotransmitter, that could be thyroid, that could be nothing to do with estrogen. So if I take these 3 main ones that she's ticked, she's put this in a 3 severity and these in a 2 severity. If I take those out the equation, because those ones could be caused by other things that aren't low estrogen, what are we left with? Vaginal dryness, so incontinence, so pelvic floor issues, that could not be anything to do with estrogen also, but vaginal dryness probably is low estrogen. So lack of control of the pelvic floor and urination, that could not be estrogen. Low libido also could not be estrogen. You could have perfectly normal hormonal profile, but you know, if just the environment that you're in isn't conducive for having good libido, then you might not have a sex drive. And again, skin and hair health, I think everyone's pretty, you know, all of us in here probably know that, you know, skin and hair health is probably quite multifactorial. There's a lot of reasons why someone's skin and hair might be problematic. Again, it could be environmental, it could be environmental toxins, it could be micronutrient deficient, it could be not enough fat, it could be too low calories. So now when we look deeper, we look beyond the section to the specific symptoms, pretty much all but one of the symptoms she's ticked under low estrogen might not actually have low estrogen as the root cause.
Okay.
Which means I can probably pretty safely say that it's actually the estrogen dominance. Does that make sense? That's kind of part one. Awesome.
Yeah.
So we need to look at the sections and kind of compare the sections, but we also need to look at the individual symptoms and know what else might be causing it. So night sweats and vaginal dryness are probably / definitely going to be low estrogen. Okay, but she hasn't ticked night sweats. She has ticked vaginal dryness. Insomnia, again, there's a lot of reasons someone can have insomnia, but that typically is going to be low estrogen, or at least it's going to be a cause. But again, she hasn't ticked that one. Okay, so we look at the individual symptoms, because there are some symptoms of a problem that could have multiple root causes, and there's some symptoms that might only really have one or two root causes. So depending on where that symptom sits, you know, is this symptom, does it only have one root cause, low estrogen, or does it have like 7 possible root causes? That is obviously going to affect your decision making in terms of, do you think, you know, is it section C, low estrogen, or is it section B, high estrogen? Okay, so you want to work through the individual symptoms as well. So I can probably pretty safely say that it's not low estrogen based on her age and based on the exact symptoms she's experiencing. So then I go, okay, cool. Well, why else might she be experiencing some of these symptoms? Okay, it could be thyroid. Thyroid could be responsible for several of the symptoms she's ticked in here under low estrogen. Now, I haven't looked, so I could be wrong, and it might be a bit embarrassing, but let's find out. Okay, I'm going to scroll down. Fingers crossed. Cool. Okay, so she has ticked 1, 2, 3, 4, 5, 6, 7, 8 symptoms under low thyroid. So maybe those symptoms under low estrogen weren't low estrogen, maybe low thyroid is the root cause. Okay, so now I'm going to dig a bit deeper, obviously try and understand her previous dieting history if I haven't already, and you know, look at micronutrient status. So this is why I love having clients keep food diaries in Chronometer, because I can scroll down and go, okay, so you know, this is her food diary that she's kept for me for the first few days. I haven't looked at it. And I can go, okay, cool. Is this a normal, like, how you eat? She goes, yeah. And I go, okay, well, selenium, important for thyroid health. Not a problem. Okay, or probably not a problem, because, you know, she's only tracked for a few days, but if she hasn't really changed what she's eaten to track, then the chances are the micronutrient deficiencies that we see based on the days that she's entered are probably, I can pretty safely say that they're going to be the same ones going back in time, right? If she hasn't changed her food sources. So, you know, I've looked at whatever day that was, and the next day selenium's good. Okay, what else is important for thyroid? Iron. Okay, iron's actually good. Copper. Okay, copper's actually good. Okay, vitamin A. Vitamin A is actually good. Vitamin D, obviously we're going to get a lot of that from sunlight, and the Bs aren't bad. So actually for her, if I'm trying to assess the root cause based on this, I'm much more likely to think it's thyroid as opposed to low estrogen. And then, okay, well, why would thyroid be low? Okay, let's consider the micronutrient angle of why thyroid might be low. We've looked at what those micronutrients are. Okay, doesn't seem like that's probably the problem for her. Now, unless she's kind of lying and has drastically changed what she's eaten to start giving me this food diary, then it probably isn't that. So yeah, there's a couple which are low: magnesium, calcium. D isn't relevant because sunlight, we never hit it all from food. B12 and E. Then if I just click on, you know, one more day, let's look at her Saturday quickly. Again, yeah, there's a couple, but it's not too bad on the micronutrient front, right? So in terms of working through that flow chart, you can see how I've ended up at thyroid. But then we want to go one deeper. We want to go, well, why might thyroid be the problem? Ideally, we always want to confirm with testing. In the case of thyroid and estrogen, obviously that means blood testing. Ideally, we want to confirm, because ideally we could be barking up the wrong tree and we might be, you know, not actually fixing the underlying problem at all. So ideally, we always want to confirm with bloods if possible. But you know, so putting that aside to 1 second, okay, is the root cause of her potential thyroid problem micronutrients? Maybe, but maybe not. So what does that leave us with? It leaves us with being underweight, which she isn't. It leaves us with a low calorie intake. You know, again, I've asked her to not change the amount of food if she can, and her calories have come out at about 17 to 1800 per day. That's not low. Sorry, that's not high, but it's also not crazy low. So, you know, maybe it's an adaptation, low calorie, yo-yo dieting thing that's happened to her thyroid, because that it has been the last few years for her. There has been a lot of yo-yo diets. So maybe that's a factor to the root cause of her thyroid. And what else could it be? Obviously, as we've looked at, it could be stress. Okay, stress. There's some other specific reasons why thyroid might be a problem. It might be an autoimmune disease. So we're getting a bit precise now, and that kind of falls out of the scope of this course. But the majority of people with hypothyroidism have Hashimoto's hypothyroidism, which is a specific type of hypothyroidism where your own immune system is attacking your thyroid gland. So there's some other kind of more precise and specific reasons why someone might have issues with thyroid, but obviously those big ones are underweight and or yo-yo dieting and or rapid fat loss and or low calories and or stress and or micronutrient deficiency. That's kind of the picture of what we see, right? So obviously then you try and assess, you know, what ones, if any, are relevant for the individual. So I've kind of gone, she's got PMS. Does she have estrogen dominance? Yes. Okay, but it also looks like low estrogen could be a problem. Upon further glance, based on the symptoms she's ticked, I actually don't think it is. Can I confirm that by finding out what else it could be instead, based on those symptoms? It could be thyroid based on the exact symptoms under low estrogen that she's ticked. Okay, is thyroid a problem? Looks like it might be. Why might thyroid be a problem? So you see how I'm kind of going step by step through this process, yeah? Does that all kind of make sense so far, mate?
Yes, basically it's sort of what I need, the step-by-step process. So it's good. At least everything is starting to make sense to me now.
Awesome. Okay, mate, great. So now, okay, so we've established that it's potentially estrogen dominance. She's got PMS, potentially / probably a thyroid component to that, right? So if I guess it would probably also work nicely here if I had that flow chart up, would probably also be beneficial. So let me open up that lesson as well. So if we click here, so far we've gone tick to the estrogen dominance, yeah, tick to the low thyroid, probably. Again, we haven't done bloods obviously at this point, okay? So that's where we're kind of at so far, okay? So now if we go back to this form, we go back to, sorry, where am I? This is the one. Oh, no, that's Netflix. I don't want the film that I was watching last night. I was watching Scarface. Never actually
oh yeah, classic.
Get rid of that. Yeah, I've never actually seen it. I only got about 20 minutes in. Anyway, sorry, back to the right tab. So okay, so now obviously, right, let's, you know, dig a little bit deeper. So if we look at this section here, I want to obviously know, you know, if maybe like sleep's a problem. So do you wake up in the night? No. Okay, cool. So it's, you know, it doesn't seem like sleep is a problem, right? Do you pass stools daily? Yes. Are they healthy? Yes. All right, cool. So it probably isn't a constipation problem for her, right? Now, I always have a conversation with the client and check like a little bit more, because, you know, a lot of the time they won't know exactly what constipation kind of means or what healthy stools are. So, you know, I will on a call ask them a bit more about how many times a week. I'll ask them about transit time. I'll screen share and get the Bristol stool chart up. So I'll just kind of confirm that to make sure, because often clients are like, yeah, they're healthy and yeah, I go to the toilet, but actually they maybe quite don't. So I'll always just confirm that on the call, but just initially so far, it doesn't look like that is a problem, right? So that is the stools. So,
Mhm.
okay, what does that leave us with? It leaves us with sleep, which we've seen maybe, yeah, is a problem. It leaves us with the gut. It leaves us with the liver. Okay, so let's look at this one, right? So, so for her, she's told me, so let's see if she's written it. Yeah, here we go. So she's told me, long story short, she's got some issues with pain and inflammation from some, yeah, so she's on a lot of painkillers and anti-inflammatories for a fairly long time, fairly consistently. So what do we now know from the digestive health lesson about anti-inflammatories? They are bad for your intestines, and they can cause this intestinal permeability, inflammation of the intestines kind of problem. So
I see.
she has said here, okay, she's actually said here, so again, I'm only just reading this, I won't take for more than 3 days a month. I could be wrong, but I will confirm with her, but based on what she told me, when these problems were a lot worse, when she had the nerve and disc issues in her neck, I think she was living on them. So she may only be taking them 3 days a month now, but I think she was taking a lot more regularly, not that long ago, like a year or so ago. So, okay, we can now see that maybe there is some issues with the immune system as a result of this intestinal permeability that may be occurring based on her being on anti-inflammatories fairly excessively. So let's scroll down and find out. Low stomach acids, a couple symptoms there. Issues with the small intestine and or pancreas. So pancreas obviously kind of being our blood sugar management and blood sugar response. There's some symptoms ticked here. So the pain in her ribs, no would be the answer to that, Alana, because that's not digestive system related. It's kind of a physical injury. I've been told a long time ago I had insulin resistance. I don't know if that's confirmed with bloods. Again, I don't know at this point. So now I'm going to go, okay, who said that to you? And what was the diagnosis? Was that fasting blood sugar? Was that HbA1c? Whatever. But good to know. I can pretty accurately guess that because knowing her body fat percentage, you're going to be insulin resistant. That's just, there's a 95% chance if you are pretty overweight that you're going to be insulin resistant. That kind of comes hand in hand, right? Ulcers and or hyper acids, okay, couple symptoms. Colon and large intestine, couple symptoms. But here you can see on this one, for example, once every 3 months, that's not exactly frequently before periods. If it's happening menstrual cycle related, what do we now know? If the digestive system problem is month round, it's a digestive system problem. If the digestive system problem is menstrual cycle time specific, it's a hormonal problem. Yeah. So it doesn't mean there's not a digestive system problem, but it just means the root cause of her abdominal cramps is not a large intestine and or colon problem necessarily, because she's only saying she has it just before her period. So that is actually then a PMS symptom. That is going to be that, everything that we're talking about, right? Liver and or gallbladder. Okay. 1, 2, 3, 4, 5. I wouldn't deem 5. So here I've written, 3 to 5 moderate priority. So I wouldn't deem 5 as like a crazy high priority, but there is something there. So now, okay, painkillers are stressful on the liver. She does have a bit of a history of drinking moderately, but that can be stressful on the liver. So now you see how we've gone through this process. Okay, it seems like she's passing stools daily. So why else might we have issues with estrogen dominance? It could be the liver. Is it the liver? She has ticked, she's actually ticked 6 because this is a 2. So I would deem that to be somewhere between moderate and high priority. So yeah, now I would definitely want to consider this liver with her in terms of not doing stuff that we know is stressful for it, if possible. So cutting out things like alcohol, and potentially considering supplementation to support the liver. Okay. Okay, so obviously a minute ago, I said based on what she is experiencing, and she seems to have a precursor to it being the anti-inflammatories, there might be some of this intestinal permeability. Okay, 3, 6, 8, 10, 11, 12. I would deem 12 to kind of be a you know, a high to moderate, a moderate to high priority. So yes. And again, we want to always not just blanket look at that. I would never go, yep, you've got intestinal permeability. I would now look at each individual symptom and go, is there a chance that this symptom actually isn't the root cause that we're looking at? And if so, what else could it be? What else might have you ticked? Okay, so now I would go a bit deeper, but for the sake of kind of looking at this just quickly, based on just glancing over what she's ticked and the amount that she's ticked and the severity of some of them, and does she have the precursors for it? Yes, in this case, a lot of painkillers. Is this intestinal permeability, this inflammation, potentially going to be a factor? I would say probably yes, right? So now I would delve deeper in terms of asking more questions and or ideally getting some tests done. So for her to go back to this flow chart, PMS, I would want to try and address and help her with the specific symptoms that she is having. Estrogen dominance, yes. Why? There are some digestive problems and liver problems, but not, at least it doesn't seem like, passing stool problems. Seems like there might be some stress and sleep problems, okay, and there seems to be some digestive problems. So last but not least, we need to look at low progesterone, right? So going back to this one, low progesterone is this one here, 3, 6, 8, 10, 12, 13. So yeah, so it seems like low progesterone is a problem. So what do we do now? We ideally want to confirm that, confirm if ovulation is occurring. And we've looked at obviously how to do that. So for her, it seems like, and it's pretty typical, it seems like low progesterone, yes, so we're going to check for ovulation. We've already discussed thyroid. Estrogen dominance, yes, seems like for her it's liver and the digestive system. Sleep and stress, yes. Is there excess body fat? Yes. Okay, cool. That gives us a shitload of information to now ask further questions, get, you know, specific plans of supplements in place, ask further, you know, do further testing if relevant. And by testing, you know, that could be bloods, it could be, you know, obviously ovulation strips for ovulation. By testing, I don't just mean blood tests. You know, it could be testing, could be transit time and stools. So she might have said, yeah, my stools are healthy and whatever, but obviously I always want to confirm that. So by testing, we could be referring to testing transit time and how healthy her stools are as well. So you can now see that I've got a lot to communicate with her, a lot of questions to ask, a lot to work on. So like the majority of people, the root cause of her PMS seems very multifactorial. And it seems to have built up over time as a result of excess body fat, the stress of yo-yo dieting, under-eating, overeating, bad food choices, poor sleep, stress. It's the kind of stereotypical picture, which is quite, lucky's not the right word, it's not lucky for her, but I took a bit of a risk there, obviously going, I haven't looked at these clients' forms, but I know she's got PMS, so let's see if it's a good example to work through. And luckily for me, that was actually a pretty fantastic example to work through. So yeah, mate, I've got about 10 minutes still. So over to you. What questions do you have from all of that?
Okay, so like usually what would be a average time, say you've given the questionnaire, your client have already answered the specifics that you need to work on in order to advise and change her diet, her lifestyle and whatnot. And in order for that to take effect, assuming everything goes well, what would you say is the average time for them to actually start seeing an improvement based on the questionnaire they've already given us?
Yeah, good question. Where is the slide that I done to answer that?
Like the time frame, I suppose.
Yes. So it takes between 90 to 100 days typically for those follicles to go from, what's the right word? Dormant / immature? No, not immature. From, not being follicles to mature, and one of them being chosen as the Graafian follicle, 90 to 100 days, which is obviously 3 to 4 menstrual cycles. Now, so because we're talking about PMS, we obviously are referring to a menstrual cycle here. So it doesn't mean that they won't see improvement. It depends when they start. If they start with you in the luteal phase, then when they're going to get that PMS might be in as little as 5, 7, 10 days time from when you start with them. So obviously they can't expect to see any improvements in the next late luteal phase because they've only just started with you. The next one is going to then be, 5, 6, 7 weeks away. So there might be some small progress. So typically what I see, but it's obviously always incredibly individualized, but typically what I see is like the second cycle that they've worked with me for, so typically 5 to 7 weeks, there's like some improvement. And then it's like typically like, it's kind of typically a little bit kind of linear, like some improvement, the next one is some improvement. And then the third or fourth one is often kind of like quite a severe night and day difference.
I see.
And that's because of this whole now follicles that aren't like there yet have gone through, have started to mature in a healthy body. So, let's say you do make some great progress and drastic changes in 30 days, then those follicles are going to be starting to mature in what is now a much less inflamed, a much healthier environment, which then when it comes around to obviously one of them being chosen, and then that whole process of ovulation and menstruation is going to be, where we see changes. Now, obviously PMS by definition is multifactorial. So some of that is going to be nothing to do with this. This is nothing to do with thyroid, for example. Okay, yes, thyroid levels have a knock-on effect to sex hormone production. We looked at that right back at the start when we looked at that pyramid. If we have low levels of thyroid, the body has a feedback loop from thyroid to the hypothalamus, where the hypothalamus goes, hey, thyroid, how much do we have? And thyroid goes, this amount. And the hypothalamus goes, oh shit, that's not much. Maybe I should then down this pathway or this signaling, I should tell, the ovaries for ovulation not to occur, because thyroid's telling me this and cortisol's telling me this, or technically the adrenals are telling me this. And I'm then receiving the fact that we've got this stressed, not optimal environment. So then I'm going to tell ovaries, don't let ovulation occur, because actually, we're not in a healthy state to reproduce here. So like, of course, everything is linked in the body. Thyroid is definitely linked to our ovarian hormones, but not directly linked in the sense that here we're referring to a time frame kind of on follicles, and that is not directly going to have any relevance or any comparison or correlation to improving thyroid. So this is just one way that you can explain example timeframes to clients. And the reason I like explaining it like this is 4 menstrual cycles is quite a long time. So if they are bought into doing the work for 4 cycles, then the other problems are typically not going to take 4 months to improve. Seeing improvements in liver, gut health, thyroid are typically not going to take 4 months. So if I can explain why it's going to take 4 months, and they go, okay, that makes sense, I'm kind of buying myself time for the other stuff to improve as well. So the stuff that isn't directly related to this typically isn't going to take more than 4 months. But it's obviously going to depend on the severity of the situation, how multifactorial it is, and if the client does the work. If you're telling the client we need to reverse diet, we need to focus on health, and every week they're just actually under eating because they're too scared to basically do what you're asking them to, then it might take that month has gone, but it might not be a month where they actually execute anything which is going to be productive in terms of fixing their problems, right? So obviously there's a lot of variables in terms of the severity. If you're in a small hole, it's easier to climb out. If you're in a bigger hole, it's harder to climb out, right? So the severity, how many things we're trying to tackle, / how multifactorial it is, that's kind of the same point. And obviously client adherence is all going to be a factor in that rate of progress.
Let's see.
How does that sound, mate? Make sense? Give you some insight?
Yeah, definitely. Because I guess like when I was trying, like when I was writing my questionnaire, the thing that was I was not confident is, say if I presented my questionnaire to my client and they have questions coming at me and I need to answer, at least give them some sort of educated answer based on what I've learned from you. I just haven't actually gained enough confidence to give them an answer that's in depth enough so they trust me, if you know what I mean. So right now, like I'm just, whenever I can, when I'm not working, when I'm not doing PT with the clients, I'm just sitting here listening to the videos, listening to how the way that you speak about it, just at least try and sound like I know what I'm doing, because this is like a completely new game changer, I believe, for me as a coach, as well as for my client as well. But yeah, I just don't want to actually leave any room for doubt for clients to feel against me, which is why like right now at least it's good that I have this one-on-one talk with you, and you have basically gone through step by step with the questionnaire and how to go about it and looking at the severity of it and working in an order that should be done. So yeah, that was like really it was very insightful. So really thank you for that.
Awesome, mate. You're very welcome. So one thing I said to one of the girls the other day is, if you're kind of thinking that would have been great at the start, again, the whole reason I've purposely kind of not let people see my health question is I want people to try and understand them, to build them out themselves, which is why there was a print screen to kind of show you, like, instead of just you having to completely imagine it. That's why I did some print screens, but that's why I didn't give it at the start or really try and show too much of it. But at this point, everyone kind of should have built theirs out now, which means I'm happy to kind of show mine. Because that really, again, I just didn't want people to copy it, because you'd be silly not to. Like, if I gave you my health questionnaire and you didn't just start using it, like, I wouldn't blame you. I wouldn't blame you if you did that. I would do that. Like, it'd be silly kind of not to. But we all know, and it's kind of my job as the teacher, if want for a better term, to be like, yeah, this might be a bit harder for you, but it's in your best interest to go through the process,
correct,
building it yourself. But now everyone's kind of, doesn't necessarily, I'm not saying they're finished, they don't have to be finished, it might never be finished, but they're kind of 80% done. Now I'm kind of happy to show you mine a little bit more, and we can use that to obviously kind of do these case studies. So I'm glad that helped. What I'll say to what you just said there is that you'll probably never feel completely ready and 100% confident. If you asked me every single one of those symptoms under every single root cause and asked me to explain the detailed mechanism, there'd be some which I couldn't. There would be some where I'm like, I know that this is a symptom, this could be a symptom of whatever it is we're referring to, and here's kind of why, at enough of a level to put it on my form. But that doesn't mean I necessarily, could give you the 20-minute deep dive of the biochemistry on how this symptom, I would be lying if I said that that's the case. So try not to stress about it too much, because ideally we do need to understand all the individual symptoms for the reasons I've said in this, to assess if the symptom that they've ticked is actually a symptom of the root cause section that we are on, or if it could be another one. So if you don't understand what that symptom is, you can't kind of figure that part out. So it is important to understand the individual symptoms. And it's also important so that we can ideally help the individual symptoms in terms of a management standpoint. But I don't feel like you have to know them crazy inside out. You just kind of need to know, like, what is the basic mechanism of why low estrogen could cause emotional instability, the serotonin receptor site activity binding precursor to 5-HTP. And then it's the same thing, but the opposite if we're referring to high estrogen and low and emotional instability. So that's kind of it. That's all we kind of really need to know about that. More's probably, of course, more's always better, but I feel like that will kind of do. And also I'd say that there's nothing wrong with saying, I don't know. Clients don't expect you to be perfect. So, you can say, I don't know, I'll get back to you to give you a bit of a better answer. There's nothing wrong with that. And also just initially, instead of working through this on calls, you know, you can just do screen records. So if you don't want to do it in real time just yet, you know, you tell clients there's a 48-hour turnaround time on check-in replies. That's standard, that's fine. That gives you a good amount of time. So, you know, if we get this up again, right? So say this was your client and you had this form, you know, you've got 48 hours to work through this, to do a bit of Googling, to refer back to the lessons, to do whatever it is you need to do to try and paint that puzzle, you know, put the pieces of that puzzle together a little bit better. And then you can, instead of doing it on a call, you can then either do the call or you can just do a screen record video, right? So it's not like you need to know all of this off the top of your head. There's nothing wrong with having to refer back to textbooks and resources. The smartest people in the world, people with PhDs, will say, I refer back to textbooks, I refer back to resources, you know, when it comes to whatever, writing content or referencing. Like, of course they do. No one remembers everything off the top of their head. It's not to be expected. So there is nothing wrong with, you looking at this, you know, going, I know enough to feel confident giving this to my clients, but I still ideally want that little bit of time to go over it, make some notes, collect my thoughts, and then do a screen record reply or then jump on a call. It doesn't have to be done in real time. So for me, I feel pretty confident with it, which is why I don't mind just opening up a client's forms that I've not looked at and then just doing it on a call and working through it as we go. I feel fairly confident with it now. But I've had these forms for a couple of years. So it's obviously a bit different. You know, I can't actually remember off the top of my head, but I probably didn't look at these forms for the first time at the same time as doing a client call. A, because it's not really probably professional to do that actually anyway, and B, because I definitely didn't have that same level of confidence when I first built out these forms as I did now. But if I waited until I did feel confident, I probably would have wasted at least a year, or I could have been delivering better results and helping clients more. So always remember that your own like little insecurities are kind of selfish, because they are holding back, in this case, this questionnaire from being in your client's hands, which is obviously affecting your ability to deliver the best service that you possibly could.
Understand.
Awesome, mate. We've got a couple more minutes. Do you have any other questions for now, mate?
Oh yeah, all right, I might as well ask since we're at it. I see that you've posted there's going to be a level 2. Can you talk a bit more about that, as to how is it a continuance from level 1 or what is it?
Yeah, awesome, mate. Thank you for asking. So basically, my initial plan of this was to have a level 1 and a level 2. And then I decided to change my mind on that. So for the next intake of the course, which opens today, it's just going to be one 20-week course, not a level 1 and a level 2. Obviously,
okay.
You've already done level 1, so you're not only going to get the level 2 part of the next one, you'll get all of it. So you'll be in the Facebook group from the start. So if you want to jump on the lives again or whatever, you can. But basically, the part of it that's going to be new for you is the level 2 part, which technically is like the end of July, start of August, where the level 2 part will start, which is just the second half of the course now moving forwards, because moving forwards, it's just one 20-week course. But because there are some extra lessons from Dr. Jess on anatomy, and because there are some extra guest lessons, I want to get, if you do decide to do level 2, I want to get you into the next intake from the start, just so that you can do the extra new lessons with Dr. Jess and the guest lessons, etc. So the next intake is 20 weeks, but obviously you've already paid for / done half of it. So the next course is twice the price. It's £1,200 instead of 600, but obviously, you don't have to pay the full price. You've already paid for technically half of it. Half of it's not new. So it's just the same investment again, but you will get 20 weeks of access to me. I mean, a couple of the weeks you'll get anyway, because we're on week 6. So a couple of the weeks you'll get anyway. There's a bit of an overlap. So, it's going to work out. You get 16 to 18 more weeks of access to me. You can jump on the lives for level 1 again if you wish. There's guest lessons. There's a new syllabus from Dr. Jess. And from week 11, there'll be new lessons, which is then technically the level 2 part. And that's really where we get into some more female specific situations, syndromes, diagnoses that we don't have a chance to cover in level 1. So that is the loss of the menstrual cycle, which we kind of covered with Victoria, but then the PCOS, the endometriosis, the hypothyroidism, the menopause, the birth control. So yeah, it's the same format again. Yeah, I think that's pretty much it in terms of what's new or what's different, mate. Does that all make sense?
Yes. Yeah, I'll definitely have a good think about it. Like you said, if I do decide to take, maybe it'll be a good time for me to sort of start from week 1 again and actually go through all of it. Because I actually really want to put what I learned now into practice, but of course with some kind of guidance as well. My last question is like, what week are we up to now in terms of the level 1 before we finish?
So we ended up making one of the lessons where I added a couple of slides. Instead of it just being week 4, it ended up being like 2 lessons, so week 4 and week 5. Then we took a pause week. So today's lesson, which I'll upload, is technically, it was week 6, but now it will be the 7th week's lesson because we've done an extra lesson and we took a pause week. So it's actually week 8. Which means that we are technically at week 8, I believe, which means that actually this intake will end up being 10 weeks because there is
10 weeks.
Yeah, there's 2 more lessons to get through, basically. So out of this presentation here, which is today's one, which you'll see uploaded in the group, this one is like 65. Yeah, this one's 65 slides. So that's 3 lessons worth. So today's lesson, which we've done, which I'll upload into the group today or tomorrow. And then the rest of this will be 2 more lessons. So they'll end up being 2 more weeks, basically 2 more Mondays. So there'll either be a 1 week overlap or there'll be no overlap between this one's finishing and the next one starting.
Awesome. That makes a lot of sense. That's good.
Awesome, mate. Perfect. So for you, mate, just book in for that one-on-one call in, whenever this week or next week works for you, so that we can have a look at that form together.
Sure.
And yeah, we'll go from there.
All right. Can't wait.